Welcome to another episode of Go Ask a Nurse, where we educate, empower, and bring clarity to the health questions that truly matter. I'm your host, Anna Marie. Today's episode is one that touches every family at some point in life, yet it's also one of the most misunderstood topics in healthcare: hospice. I'm honored to be joined by Tara, an RN who brings years of leadership, compassion, and world experience walking families through some of their most vulnerable moments. Today, she helps us break down what hospice really is, who it serves, and how it supports patients, not just medically, but emotionally, spiritually, and holistically. If you've ever wondered when it's time for hospice, how it works, or what care looks like in the final stages of life, this conversation will bring peace, clarity, and answers. Hospice is not about giving up. It's about living with dignity and comfort. And today we're going to talk about exactly how that works. So let's dive in. Thank you, Tara, so much for being on Go Ask a Nurse.
Thank you. Thanks for having me.
I'm so excited about our conversation today. This conversation is actually a tough one, but it's an area that is holds very dear to my heart. And this is how we met
Yes, it is.
a while back, both being hospice nurses. Tara, so tell us a little bit about where you're at with hospice now. What do you do?
So currently I work for a hospice in Texas, and I mostly leadership, audits, billing, insurance type things, but it has well evolved. I started in hospice in 2004 after doing a series of what used to be called med surge. I'm not sure if that's what it's called anymore because I feel old. Um, and why did I choose hospice? I think hospice probably chose me. It's not something I ever thought about going into. It's not something I looked up ads for, but I was sort of tired of that. When you go to the hospital, that's what I was doing. I guess, you have little time in the hospital to really sit with people and talk to them about their life.
So, Tara, for all the listeners who may not fully understand hospice, how would you describe what hospice truly is and what it is not?
I would say hospice is truly living well and living life to its fullest. What it is not is a death sentence. You don't get on hospice and die the next day, is how I would describe it.
That is probably what has been one of my favorite parts of the job is really getting to know the families, not just the patients. It's
Right,
the family. They take you in as part of their family because you're caring for their loved one at such a vulnerable time of life.
right. Agreed.
What are some of the biggest myths or fears you encounter about hospice?
I think the biggest myth, you take patients on in hospice at what we would say end of life, and really regulations are driving that. What they say is end of life. I think that's a big myth. You go on hospice and you're going to die right away. Most people don't, some do. The other myth I think is a big one is that if I go on hospice, they're going to start me on meds that will kill me. The biggest one being the morphine. Morphine kills people. I've heard that a lot lately. So I would say those are some of the biggest. And another big myth is that when you sign on for hospice, you're just giving up on everything. You're done. You're not, you don't want to live anymore. You don't, which is not true at all.
Some of the biggest things that you would say then would be really educating the family on the medication.
Right.
And it's
And
really,
just, I think what hospice is in general. And I know the two words go together. You say hospice and you immediately think death or dying are what your mind goes to. And I said, it's everybody that happens to. So you're right. It is a big piece of educating. This benefit is yours to use. Why wouldn't you?
I think one thing I really want to emphasize is when we start people on morphine in hospice, we are not starting at high doses of morphine.
Absolutely.
It's so low, but you have to think about your loved one and you got to think about yourself of how you would want them to be comfortable. It's allowing them to be comfortable in this process. Does everybody need morphine at the
Right.
beginning? No.
No.
And the time it should only be given is when they absolutely need it or show signs.
And I think too, there's some patients that have said, I don't want any kind of, if they're more conservative and they say flat out in the beginning, I don't want this medication. And so, you honor that and hope the family honors that too. But sometimes you do have to make that decision. You do not want patients and families emotionally to suffer, as things do decline.
And the other part that you mentioned as one of the myths of going on hospice means death. I mean, we have personally seen people graduate from hospice, but the advantages of going on hospice is really there for the people to take advantage of everything that comes with it, the help, the support, the cost of so much, when you think about it, of getting the proper bed. Um, I think that extra help is really important to help them shower,
Right.
to give the loved one a little time to have a little time to themselves because caring for somebody who is actually at that state can be really exhausting.
And I think too, from a family perspective, I think sometimes people just need to vent about and for somebody not to have judgment on that. Sometimes different family members, if they vent to each other, they develop judgments on how one person is handling the situation versus how the other one is handling. We get a lot of questions like, don't you think my brother should be here? Well, everybody has their own way of doing things. And so if your brother doesn't want to be here, he doesn't have to be. And so I think we're kind of that, whether it's a hospice nurse, a hospice aide, a hospice social worker, just kind of a moderator where there's no judgment on how they're handling it, but we can be there to listen to them.
Many families wait too long before choosing hospice. Why do you think that is?
It just has a stigma of death around it. They wait too long. And so then families become in crisis mode, like they recognize the change, and the patient is in the dying stages at that point. So it's kind of an emotional, physical, spiritual crisis all at once. So I think families and patients wait because they're scared of the word.
I agree. And once you put that label,
Right.
it's actually coming to terms that this is the end of life.
Hmm.
Um, I think one of the biggest things I encourage, and as you continue doing this, if you agree or not, having those conversations with the family because I I honestly feel and have seen and witnessed that it is harder for the family members than the actual person dying
I would
through
agree with that.
through this process. So if your loved one is the one going through it, I think the one thing that they need to hear and what I've heard from my patients is that their loved ones are going to be okay. Like
Right.
having those real meaningful conversations when they are alert and oriented and can, because at some point they're not, and it's not going to be that they can't hear you, they just won't be able to talk with you.
Right. And I said, it's hard. We go to the hospital to get better. I do feel like even if you're younger, the first time you go to the hospital, somebody should just talk to you about, hey, what are your wishes? Like, do you have a POA? Do you have I know those are hard things when you're younger, but if you can have those things ready to go, I think when whatever happens, whether it's you die in an accident or things are ready for the people that are still here. So you've prepared essentially kind of ahead of time for your family's emotional well-being.
Once a patient elects hospice, what does the first 24, 48 hours look like?
Um, I would say it's probably a busy time for the patient and family. I know a lot of families or patients will say, I don't need a chaplain, I don't need a social worker, because social worker too connotates like social services, um, sort of thing. So they'll kind of decline all services. Really, we like to get all of the team in the first 48 hours just to meet the patient. We are coming into their home, like you said. We want to make sure that the right staff members match up to the patients. If you don't like somebody, just say it and we'll try a different nurse, we'll try a different aide, we'll try a different social worker. We want to get to know you and the family while it's not a crisis. So I would say it's very busy for the patient, even in that first week. Um, because everybody's coming in, and sometimes that can be a little overwhelming for patients and families. But I think if they know you ahead and have a personal connection with you, it will last throughout the whole service.
Absolutely. Can you walk us through like your interdisciplinary team, like the nurses, the
Yep,
CNAs, the chaplains, social workers, and how each member supports the patient?
sure. So every patient has a team, and really it's up to the patient and families. They kind of, like I said, decide who they want, what they want, and when they want it. So our nurses are the case managers. So they kind of run what we call the plan of care, which looks like the medications that they're on, making sure their symptoms are under control, making sure we have their wishes, identified, what goals they want to meet. Uh, they're kind of, I would say, running the other disciplines a little bit. They know when an aide needs to come in. They can assign a chaplain to come in if that's what the family wants. Your aides, I mean, currently for the hospice I work for, we like to start our aides out right away, even if it's just one day a week, because we believe that the aides are like our caregivers. They do it all because they go in the most frequently typically. And so they have connections with patients and families that the nurses or chaplains or social workers don't always have. The CNAs provide what I would say your care cares or your activities of daily living, help with bathing. Sometimes if somebody has already caregivers or family that are doing those things, we still want our aides to go in and get to know the patient, whether it's they sit and read them a book, they sit and hold their hand and just tell stories. We still encourage our aides to go in, even if they're not providing any cares at that moment in time. Our chaplains, they provide the spiritual support. And when I say like some of us can do all the things, like the CNAs know when there's a symptom issue because the patient's not the same as they were the day before or 2 days before that. So everybody can kind of cross over a little bit without taking on a different scope. But we know when our patients look different, act different, or families are acting different, or something is missed in the home. So our chaplains kind of do the spiritual work of hospice. And sometimes it's just nice to have that. It might be that, like I said, they sit and hold hands or they sit and pray. Not everybody believes in a God. So when we say chaplain, we mean spirituality, whatever that looks like to the patient. Social workers, they're kind of the same. They can do it all. Social workers for me are a big resource mecca. They have resources for private caregiving. They have resources for, you know, income, those types of things. They know all the ins and outs of, I would say, insurance, all the things. So they just help patients too, I would say, with their emotions, emotional stress. They help families. They help a lot to set up respite if our patients need respite services, just to give caregivers a break. So each member supports the patient. We support, I would say, the patient and family is at the center of the circle. And the hospice team then is around them. And then you have kind of your interdisciplinary team. So it's not just nurses, CNAs, chaplains, social workers. We also have volunteers, but the patient and family are also a part of our team. We need them to be if they want services as it looks to them. That's really what we're there to do, is to honor patients and families' wishes.
How would you say we're honoring their quality of life, comfort, and dignity?
So I think, it's not the hospice team driving the bus, it's still the family and patient. What happens is if I need to help out more, I move as a nurse or an aide or chaplain or social worker. We just move to the front of the bus closer so that we know more what your needs are, we never take over driving the bus. That's always the patient and family, if that's a good analogy. But we also want to make sure sometimes what families think, or, outside friends also, when you see a patient or hear that a patient hasn't eaten in a week, but they look totally comfortable, that's hard for people. So when we say quality of life and comfort, sometimes that looks different to other people. It's based on, did you eat? Did you do these things? Because if you don't do them, you can't survive and you're definitely not comfortable. Quality of life to me is what does living well mean to you? What does that look like? Is it to eat whatever you want when you want? Then I would support that. If I wasn't as a hospice person or your hospice team taking care of you, would you do the things that you wanted to? Absolutely, you would. And we want to encourage you to do those things. So, whether it's emotionally you're comfortable, physically you're comfortable, spiritually you're comfortable, we want all the things to be in place and really for you to have peace in your life with what's happening.
What clinical
Thanks.
signs or disease progressions often signal that someone may qualify for hospice?
I would say we miss out on a lot of the little things, like your loved one has been to the hospital 3 times. 3 times they've done the same intervention. 3 times they've come home. The likelihood that they'll go back is high. So I would say when you start to see these types of things, that it could be just you're talking with your family and you realize something's a little off with your loved one. Or some people that, let's say they have cancer, and it might be the cancer treatments don't seem to be doing a whole lot anymore. Like you're still not feeling well after a week of chemo. Um, that it could be simple things like you don't get out of the house much anymore. You're withdrawn from the world. It could be you're not eating as much, or you live alone. And so your family or friends aren't really sure what's happening during the day. But when they come to see you, they notice a change. So I said, really, all of those things kind of put you in a place where you could qualify for hospice. But I will tell you from experience, even if you're aware of these things, nobody thinks of hospice first. They always think of hospital, clinic, those types of things. So I would say, everybody typically has a different disease, but little things like you're not going out as much, you're not moving around the house as much. I come over and you're still in bed at 10 a.m. When you used to get up, your routine is getting up at 7 or 8 and you have a routine, but you're not following it anymore. Subtle changes in your lifestyle or your habits or your routine or your physical condition, what's happening, are all signs that you may qualify.
Kind of give an example of where, we see those signs of decline and then would cause somebody to graduate from hospice.
Good one. Tough one. So if you graduate from hospice, hallelujah. But what happens is you have a lot of visitors in with hospice. We're managing symptoms. And so we would never just discharge somebody to discharge them because they haven't changed. What if you are not declining per, most of this is per Medicare regulations. So if you're not declining and the changes aren't happening as quickly as Medicare would like, you could be discharged or graduate from hospice. I always say the best thing to try first is pull out some services. If a nurse is seeing a patient 3 times a week, take the nurse down to 1 time a week. When a patient loses support, typically you will see a decline. And so they can stay on. We have had patients graduate because, again, when you take patients off, we have no idea. When you take a patient on, we have no idea if they really have 6 months or less. I mean, I can guess based on what I'm seeing, but if there aren't huge changes, I mean, we do have patients graduate, which is great. And then as family, we really educate to say, hey, if something changes, please notify us and we'll come out, even if it's the next day, the next week, and just reevaluate to see if they meet hospice criteria based on Medicare specifications.
How often do you typically see people come back on hospice once you start taking services away and they don't have all that extra help?
So you will see patients decline in the first week. So if somebody has an aide 5 days a week and they're just not changing, we'll try and take the aide down to 3 times a week. And then one, typically in 2 weeks, we can't even discharge patients because they've declined. And so it goes to show that hospice is doing what they set out to do by having the care in the home, the symptom management, the, all of it, emotional and spiritual support. Really, patients are living well and living longer.
How does hospice support the family and not just the patient?
So, I mean, it's a whole piece. So, yes, we want to symptom manage the patient. We get to know the patient. We also get to know the family because if the patient can't necessarily talk to us or doesn't have a good, they're not good historians, we need the family to help us. And when you visit, the family's sometimes there. So, it's about supporting them because if you don't support family, they can't support the patient either. So it's a lot of our social work, chaplain, even our nurses, and sometimes our aides too. When a family's in the home, they have questions, they have issues in their own personal lives that, again, we're trying to support all of it. Because if we support the whole family, not just the patient, the family can support the patient better.
What does the active dying phase look like, and how does hospice help families through it?
You ask hard questions.
I know.
So, when we talk about dying, I try and correlate it to living. If you asked, what would the living phase look like of your life? Everybody's different. And so people do die differently too. So when you say active dying phase, I would say people are unresponsive, but they can still hear. It might not be exactly what you're saying, but they hear you, and I think they recognize your voice. Sometimes there's like staring at nothing or staring through the people that are in the room to something else. They pick at the air. Um, they don't eat. You know, when you overwater a flower, it dies also. So imagine overwatering and overfeeding somebody whose body doesn't need that anymore, then they also can speed that up by trying to feed them and give them a lot of liquids. Um, those are a few things. I would say sometimes there's some restlessness, and you don't always know what that's from, if it's emotional, spiritual, physical. So sometimes we do use medications for some of that restlessness. And it's not always that this dying phase, I would say most times it's not bothering the patient at all. It's uncomfortable for the families. So you can't medicate families. So that's where that emotional, spiritual aspect comes in. You really support the families in that way because that's where they're suffering the most. So active dying can look many ways. I've had patients that their vital signs, I typically don't take vital signs when somebody's in the active dying phase, or what I think looks like, hey, it might be, 72 hours ish. I always tell everybody it's a guess. I don't know. I think that's what the dying phase looks like. Your physical, your ability to communicate or understand what's happening changes. So I always tell this story. I had one patient when I was new to hospice. I didn't know, my training wasn't very good because there were no nurses really to train me. Um, he lived for 5 weeks without food or water. And so for me, that was very painful and emotional to watch. So it is hard, but I have some patients, their vital signs are good. They're talking to me, and 5 hours later, I get a call, and then families will say, I think they passed. And I'm like, I was just there. How can that be? But sometimes it's just they're ready and they're like, okay, this is it, I guess.
It's like they get, I mean, I have seen that where they get that last burst of energy and they had a
Yes,
great day and then all of a sudden
they're just gone.
they're gone.
Yep. So
I,
yeah, it's hard to say. I think there maybe are some things that are similar, but I would say everybody has their own personality, and not only does that play out in life, it also plays out in death. If you're tough and stubborn, you might go for days without food. So I think it's hard because or families will step out of the room, they've been sitting forever with a patient. They'll step out and the patient will pass. And they feel guilty, and I'll always ask, well, was your loved one like, did they like people, or did they kind of do things on their own? They were tough, they just did life. And I'm like, well, that's probably how they wanted to go out too. It's not like one personality in life, one personality in death. They're the same person.
mhm.
It's just a different part of their life.
And I always like to emphasize that, their hearing is the last to go. So even though someone's
Right.
unresponsive, they hear you.
Families too are scared to like have normal conversations or be doing the things in the house that you always did. They're used to that. Even though they might be unresponsive, they understand that still and they can hear that. So if there was silence for like 24 hours, I mean, these people might get restless because they don't know what's happening.
Favorite stories is when one of my patients, I was on vacation and I came back and he was perfectly fine before I left. And then all of a sudden I come back and he's unresponsive. And I was like, wow, this happened fast. It was just a weekend. And I went in and held his hand and he could never get my name right. He always called me Annabelle. And so I held his hand and I said, "Hi, so and so. It's Annabelle." And I got a smile out of his face, and his family was just like in shock. Like he knew who I was, but couldn't talk and being unresponsive, but he smiled.
Right.
And oh, that was just one of my favorite memories of just how even though they're unresponsive, they know, they hear,
Right.
and
They're still
yeah,
happy to see you. So, I mean,
yeah, it's that reminiscing and however you all are, that's how I tell the families. They love to hear that. Just reminisce with them and tell them all the good things. And how does someone enroll in hospice? Do they need a referral?
so that's a sticky question. When you say referral, I always think doctor, and I'm sure that's what a lot of people think. So anybody can refer to hospice. You just have to call a hospice and say, hey, I think my loved one needs hospice services. I'm uncertain. And most times, somebody from a hospice agency will come out, visit with you about what it is, and talk to you. Uh, so, yes, kind of a referral, but the referral can come from anyone. It's not like you have to call a physician and say, I need a referral to hospice. You don't need to go about it that way. So you can just call a hospice agency and say, my loved one, I think needs hospice. And somebody will come out, whether it's a nurse or a community liaison to educate about what it is and go from there.
That is a good point because that's one of those other myths that you do need a referral from a doctor or anything to
Right.
even go on hospice services. What support do you offer to family caregivers who feel overwhelmed, especially during that part where they are really in the active stage? And I know a lot of people don't know what to do during that stage. They're very
Right.
emotional.
So we will during that stage, we have what we call the Akira hospice scale is what we use at our it's helps more to say where they're kind of at. Like it's a numbered scale. Are they warm? Are they cold? Are they eating? Are they mobile? Are they So the other thing we do to offer, we have volunteers that will come out and sit. We increase visits so that we're there more to support the family. Because most times in that dying phase, the patient is very comfortable in all realms and everything. It's the family who needs us more. So I might go for a nursing visit, but really, I look at the patient, I do my assessment, but most time is spent with the loved ones who are dealing with it, who feel overwhelmed. The other thing we do, you can do, it's not really recommended in the active dying phase, is respite. But sometimes the caregivers feel more overwhelmed kind of before the active dying phase or stages, where they're trying to do all the caregiving. They don't know what to do. The patient doesn't know what they want. It's a lot on families. So we do offer even bereavement services. Our bereavement coordinator will go out before and talk to families and support them and give them resources where sometimes people will go to grief groups before their loved one has passed because you're still grieving the loss that that's going to happen. So we use the interdisciplinary team. We also use the bereavement coordinator. Volunteers can help support the family. And sometimes it's just to educate them. Like I know a lot of family or caregivers are feel overwhelmed in handling if they are utilizing morphine, some of the medications that are in the comfort kit. They feel uncomfortable because they're handling those meds. And a lot of it is just education about what's going on and like, hey, what was your loved one? How did they look yesterday? How did they react? How did they respond? A lot of times, too, a big part of the education is teaching people what nonverbal signs and symptoms of pain or discomfort look like. It could be their restlessness, it could be, the picking at the air, constantly looking like they're trying to get out of bed, even though they might be somewhat unresponsive. So it's a lot of education and just, I would say, hand holding and talking to family. Maybe there's an underlying for a social worker. The loved one caring for their loved one has something underlying going on, a struggle they're dealing with. Well, we would help that person too. It's not just for the patient what we do. Because when the patient is gone, the family will still be here.
You continue to offer
Yep, the
bereavement.
bereavement support. Bereavement usually goes on for 13 months after, and that is totally dictated how the family wants it. So you could have weekly follow-up calls. You can actually meet with bereavement support services. They'll come out to your house. Some families, they're what we would consider low risk bereavement, and they don't want a whole lot because they feel like they're dealing okay with it. But they can always call us, and they can even call us after the 13 months. And if they're having issues, we can do community bereavement also.
How is hospice paid for? What should families know about Medicare, Medicaid, or insurance coverage?
So, Medicare and Medicaid, if you have Medicare A, everything's covered. That's part of the Medicare A benefit. One thing they should know is Medicare A also covers hospital, home health, and skilled nursing care. And you can only have one of the four. So if you go to the hospital and you're on hospice, you can't have both. So you have to pick one. Um, Medicaid is similar because they're both, run by CMS, um, paid by Medicaid. Medicaid offers two, if you qualify, if you're at a facility, room and board. Medicaid room and board will cover your expenses in that way. Or insurance coverage, which is your private insurance like Blue Cross, Blue Shield, United Healthcare's. They sometimes dictate what you can and can't have on hospice, or you choose to pay for certain services that your insurance might not cover. Not all hospices are in with all insurance providers. Um, these days, it's very difficult to get in what I would say in network with insurances. So, most hospices, I would say it's Medicare and Medicaid. Insurance will cover. You just have to, the hospice has to call and get authorization for the services. And then there's also, you can pay privately for hospice if it's something you want. So there's that also.
And how quickly can they start?
How quickly can they start? Um, if you qualify for hospice, after you decide, you sign a consent and you can start the day that you sign the consent.
Equipment or supplies does hospice typically provide in the home?
So, hospice is required to cover all the equipment and all the supplies. Now, with that being said, it might not cover the exact supplies that you want. Hospices use, companies to provide them supplies. So, for instance, wipes. We've had patients that want flushable wipes. Well, most companies, whether it's Medline, other companies, they don't ship out or have in stock like flushable wipes. So you get all the supplies are covered, all the equipment is covered. It's just a matter of like if you have something very specific instead of what hospice supplies you, you could get those on your own if you wanted. But typically, all the equipment and supplies that you would need would be covered by hospice.
And
And
medication, correct?
yep, and medications.
And you were talking about a medication kit that you probably initially start with, correct?
Yes, correct. The comfort kit. So it comes with a little bit of, I say, everything. And really, what the comfort kit is meant to do, we don't get prescriptions for all of it. We get a comfort kit. So it has a little bit of medication in it for pain. It has a little bit for anxiety. It has a little bit for agitation, a little bit for constipation, for fever, for nausea, vomiting. So it has, I think the ones we're getting now have 6 meds in them, uh, some suppositories, but that's for, hey, we know you don't need it or want it right now. But if you would call hospice in the middle of the night, not very many pharmacies are open 24 hours a day anymore. And so we just have those things in the home in an emergency. So that way I can come out to your house, see what's going on, assess the situation, and I have a few things that I could work with if it's something you need medication for.
Once your family, your loved one passes, what happens then? What are your steps at home that the family member should do?
Don't call 911. So if you think some people are unsure if your loved one has passed away, you just call the hospice number of whatever hospice you're working with. From that point on, the hospice will help you handle everything. They will come out, um, whatever in whatever state is required. I'm not sure in the state of Nebraska anymore if it's still required that a sheriff comes out to basically pronounce. In Texas, an RN can pronounce death. So they would do that. They would call the funeral home that you've picked, wait until the funeral home came, help that, just help you get situated, help you arrange a time to meet with your funeral home if that's needed also. So it's a pretty, things are in place. The other thing I would say is I know people kind of have an issue with that whole DNR thing. You do not have to have a DNR to be on hospice. So I know a lot of people, when that death happens, they think, oh my goodness, we don't have a DNR. But if you're the family or the POA, you would just direct us on what you wanted to do. If I would say, probably more importantly, is to identify who that medical power of attorney or durable power of attorney is at the time you're admitting. Whether they have a DNR or not is not like crucial to hospice admission.
Well, you answered a lot of great questions, and these are hard questions, but I know so many people out there don't understand what hospice is, and they do get nervous on the phrase hospice because honestly, I don't think it's utilized enough, and I
Right,
don't think it's utilized during the time when the patient can actually take advantage
right.
of the service. And
And
it's
I always like to say it's the gold star of home care, honestly, because you get so many team members. You get to do whatever you want. Why not? You want me to help you ride a motorcycle? Is that your wish? I will try my hardest. To get to do things that you want to do. Hey, why not? Let's give it a go. So, I do think it's a totally underutilized benefit. And when it is utilized, it's at the wrong time. It's what I would say too late because an emotional crisis is for everybody at that time. Even sometimes the hospice staff coming out, it's tough to get emotions and everything under control to try and if it's 24 hours they have left or they pass in 24 hours, it's tough to get rid of the crisis and for everybody to live well at that point in time.
Can you share a moment or a story that captures the beauty, comfort, and humanity of hospice care?
Oh my goodness, yes, there are so many, but I will tell you, I had one gentleman. He lived, it was a like log cabin, him and his wife. And then the family built on and they stayed with him on the side of the log cabin. But he was a woodworker And he had actually built his own coffin out of like wood. He had a wood shop in the back. He built him and his wife coffins. And his wish was that when he passed, that we, as the hospice staff, would put him in the coffin that he built and put the quilt that his wife made for both of them over the top of him. And so, that's hard because that's not how we do it or how a funeral home sees fit. So we found a funeral home that would help us honor his wishes. And so he did have to go to the funeral home to get prepped and everything, but they buried him soon enough on his property that he didn't have to be embalmed. We did all the things. We put him in the coffin, we covered him. The funeral home took him until the funeral to their, funeral home, I guess, if you want to call it that, to just keep him until the funeral. So then they brought him back out to his property and they had a funeral in the back, like in the pasture, and they just buried that coffin into the ground. They dug a hole, buried it, and did as he wished. So it was really beautiful. He was a great guy, funny. Like he even took me out to his woodworking shed to like show me all that he did. He couldn't walk that well, but he was super proud of it and that we could do that. And his wife and his family saw that, yes, if this is what you want, we'll help make it happen. And to have that emotional and spiritual comfort. Sometimes people are more scared and restless because they're uncertain. I'm telling them this, will they make it happen? I don't know. And so I think people do get emotional, like they're uncertain, they're afraid that their wishes aren't going to happen. So to make that and have the family see that, yes, we'll do this. This is what he wanted. I mean, he made a beautiful coffin. The family took a picture of him in the coffin and sent it to me, which is weird. When they had the little viewing at the funeral home for other people. But I'm like, look, this guy made this and we were able to do that. This is the quilt that his wife made, just to prove to myself, too, that look, we made this happen. I can make other things happen if that's your wish.
That's what hospice is. I
Yeah.
want everyone to know that's what hospice is about. It's one of my favorite stories is I had a patient that was in the Hall of Fame um, at a university, and he was in, gosh, his late 90s. But I got the whole entire baseball team to come and see him. And
That's
my goal
amazing.
was to get him out there to throw the first pitch when they had opening season, and COVID hit and messed
Oh,
everything up. But the team got to come in and see him, and he was so, they were so in awe of him, but he was so in awe of them. And it was
right.
such a beautiful day. And that is what's fun. And
Right.
when you think about a great hospice organization, that they will do things to make things so beautiful for your loved one and family member and for the family. Um,
And I think to make death less scary. Like we
exactly.
know it's going to happen, but we don't want to know that it's going to happen. So we try hard not to think about it. But if you can make your death just as beautiful as your life, I think it's a good thing.
Absolutely. Tara, thank you so much for being on today. And thank you for what you continue to do out there in Texas. And to all the other hospice nurses and hospice providers, thank you for everything that you do for these families. Thank you for joining us on this heartfelt and meaningful episode of Go Ask a Nurse. Hospice is one of the greatest gifts we can offer a loved one: comfort, compassion, and dignity at a time when it matters most. And understanding it removes fear, empowers families, and helps people make decisions with peace instead of panic. A huge thank you to Tara and all the hospice nurses out there for the beautiful work they do every day. Your compassion changes lives. If this episode helped you, Please share it with somebody who may be facing a difficult diagnosis or caring for an aging loved one. Education is empowerment. Stay informed, stay empowered, and always be blessed. The information provided on this podcast is for general informational and educational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition or health concern. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. The views expressed by guests on this podcast are their own and do not necessarily reflect the views of the host or Go Ask a Nurse.